Orthopedic examination of thoracolumbar region. Examination of thoracolumbar region starts with inspection. Ask the patient to stand. Look at the spine from the side. Try to make an assessment of the thoracic curvature, noting whether the curve is quite regular or if it appears to be increased. Ask the patient to bend forward, carefully examining the flow of movement in the spine, and whether the curvature increases. As the range of flexion in the thoracic spine is small, it may also help to check rotation, which is the main movement occurring in the thoracic spine. Now ask the patient to stand upright, and brace back the shoulders, to produce extension. An increased curvature, kyphosis, which is regular and mobile, is found in postural kyphosis. If a regular but fixed kyphosis is found, the commonest causes are senile kyphosis, Schwann's disease, and ankylosing spondylitis. If there is an angular kyphosis, with a gibbous or prominent vertebral spine, the commonest causes are fracture, tuberculosis of the spine, or a congenital vertebral abnormality. Note the lumbar curvature. Flattening or reversal of the normal lumbar lordosis is a common finding in prolapsed intervertebral disc, osteoarthritis of the spine, infections of the vertebral bodies, and ankylosing spondylitis. Flexion of the spine, hips, and knees is suggestive of spinal stenosis. An increase in the lumbar curvature may be normal, especially in women. Or it may be found in association with the prominence of the spine of L5 and the sacrum in spondylolisthesis. It may be secondary to an increased thoracic curvature, or to flexion deformity of the hips. Always screen the hips. Note café au lait spots, which may suggest neurofibromatosis and associated scoliosis. Note a fat pad or hairy patch, suggestive of spina bifida in children. Any scarring is suggestive of previous thoracotomy, and possible thoracogenic scoliosis or spinal surgery. Check for scoliosis by noticing the presence of any lateral curvature. The commonest scoliosis is a protective scoliosis in the lumbar region secondary to a prolapsed intervertebral disc. Note whether the shoulders and hips are level. In considering other causes of scoliosis, examine the spine with the patient sitting. Obliteration of an abnormal curve suggests that the scoliosis is mobile, and may be secondary to shortening of a leg. Certainly the next step to take is to check and compare the leg lengths. If, on sitting, the scoliosis persists, ask the patient to bend forward. If the curve disappears, this suggests that it is quite mobile, and most likely to be postural in origin. If the curvature remains, this suggests that the scoliosis is fixed, which is known as structural scoliosis. If a rib hump is present, this confirms the diagnosis. In the case of infantile scoliosis, assess the rigidity of a curvature by noting any alterations as the child is lifted by the armpits. In idiopathic scoliosis with double fixed primary curves, the deformity may not be obvious. There will, however, be shortening of stature, with a trunk which is short in proportion to the limbs. The next step is palpation. Ask the patient to lean forward if possible. Look for tenderness between the spines of the lumbar vertebrae and at the lumbosacral junction. As shown in point A, it is common in prolapsed intervertebral disc, but thought difficult to explain and unreliable. Then palpate the lumbar muscles as shown in point B. This is especially likely to be found where there is protective muscle spasm, in cases of intervertebral disc prolapse, and mechanical back pain. Palpate to check the tenderness over the sacroiliac joints. As shown in point C, it may occur in cases of mechanical back pain, and in sacroiliac joint infections. If tenderness present, then re-examine the patient in prone position. Check for renal tenderness as shown in point D. Also look for tenderness at higher levels of the spine as shown in point E. With the patient standing, slide the fingers down the lumbar spine onto the sacrum. A palpable step at the lumbosacral junction is a feature of spondylolisthesis. Next step is percussion. Ask the patient to bend forward. Lightly percuss the spine starting from the root of the neck to the sacrum. Significant pain is a feature of tuberculosis and other infections, trauma, especially fractures and neoplasms. Then moves towards movement assessment. To check the flexion, ask the patient to touch his toes, while you watch the spine closely for smoothness of movement, and any areas of restriction. Flexion may be recorded in several ways. The commonest way is to note the distance between the fingers and the ground. For example, the patient flexes to within 10 cm of the floor. This is an indication of the summation of thoracic, lumbar, and hip movements. It does not distinguish between them. When the spine flexes, the distance between each pair of vertebral spines increases. So spinal flexion can also be recorded by measuring the spine when the patient is erect, and then when the patient bent forward. Any increase is clear evidence of spinal flexion. In practice, this is used most frequently in assessing movements in the lumbar spine. One of the most efficient way to measure spinal flexion is Scober's method. First, palpate the posterior superior iliac spines and mark 2 points on them. Then draw a line by connecting the 2 points. Then place measuring tape on the line and mark 2 points, 10 cm above and 5 cm below to that line. Anchor the top of the tape with a finger, and ask the patient to flex as far forward as he can. Note the increase in distance between 2 points. This is normally increase about 6 to 7 cm. Less than 5 cm is indicative of organic spinal pathology. Flexion in the thoracic spine may be measured with this Scober's method. Mark an upper point 30 cm above, from the horizontal line, joining the posterior superior iliac spines. Thoracic flexion is not great, and normally you can see the increase of about 3 cm. Check the spinal extension by asking the patient to arch his back, assisting him by steadying the pelvis and pulling back on the shoulder. Pain is common in prolapsed intervertebral disc and in spondylolysis. Accurate assessment with a goniometer is difficult. The maximum theoretical range is 25° for thoracic spine and 35° for lumbar spine. The decrease in distance between L1 and S1 on extension may also be measured with a tape. Check lateral flexion by asking the patient to slide his hands down the side of each leg in turn, and record the point reached by measuring the distance from fingertips to the floor in centimeters or inches. Compare both sides. Lateral flexion can also be recorded by measuring the angle formed between a vertical line and a line drawn through T1 and S1. The average range is 30° to either side, and the contributions of the thoracic and lumbar spine are usually equal. To measure the spinal rotation, the patient should be seated and asked to twist round to each side. Rotation is measured between the plane of the shoulders and the pelvis. The normal maximum range is 40° and is almost entirely thoracic. Lumbar contribution is only 5° or less. If prolapsed intervertebral disc is suspected, always start by screening the hips. Osteoarthritis of the hip and prolapsed intervertebral disc are frequently confused. To rule out the hip osteoarthritis, a full range of rotation in the hips, performed at 90° of flexion. No pain at the extremes of motion is generally sufficient to exclude osteoarthritis. Note that, if there is complaint of pain on flexing the hip, with the knee flexed, it is suggestive of osteoarthritis. If the hips are normal, perform the straight leg raise test. Raise the leg from the couch, while watching the patient's face. Stop when the patient complains of pain, and confirm that he is complaining of back or leg pain, and not hamstring tightness. The test is negative if there is no pain. The production of paresthesia, or radiating root pains, is highly significant, indicating nerve root irritation. Note the results of straight leg raise test. If pain occurs at 60°, note the site of pain. Back pain suggests a central disc prolapse, and leg pain suggests a lateral protrusion. Repeat the test on both sides. If leg raising produces pain and paresthesia on the affected side, this is highly suggestive of a large prolapse close to the midline. If the roots of the sciatic nerve are involved, pain will be present below the knee. Sciatic stretch test. Now lower the leg until pain disappears, as shown in point 1, then dorsiflex the foot as shown in point 2. This increases tension on the nerve roots, and generally aggravating any pain, or paresthesia. If pain increases with dorsiflexion, it shows positive sciatic stretch test. Bowstring test. Alternatively, once the level of pain has been reached, flex the knee slightly as shown in point 3 and apply firm pressure with the thumb in the popliteal fossa over the stretched tibial nerve, as shown in point 4. Any radiating pain and paresthesia suggest nerve root irritation, and shows positive bowstring test. Flip test. If there is some doubt, Regarding the severity or genuineness of the patient's complaints, ask the patient to sit on the couch and examine his back. Measure the flexion with the tape in this position. The functional patient will have no difficulty in this position, but the genuine patient will either flex the knees or fall back on the couch with pain. EDS test. Alternatively, ask the patient to sit with the legs over the edge of the examination couch. Now try to lift the leg until the knee is fully extended, and note the patient's response. If complete knee extension is achieved in this position, it is equivalent to a straight leg raising of 90 degrees, and suggests negative straight leg raise test. To further confirm the prolapse intervertebral disc, apply pressure to the head. It is suggested that this aggravates the back pain. The patient should be prone. Flex each knee in turn. This gives rise to pain in the appropriate distributions, by stretching of femoral nerve roots in high lumbar disc lesions. The pain produced in such a test, if positive, is normally aggravated by extension of the hip. Look for further evidence of neurological involvement. Assess the integrity of L4 by the presence of the knee jerk. S1 alone may be assigned to the ankle jerk. Absence of one or both ankle jerks is usually a significant clinical finding, and does not occur in normal individuals below the age of 30. Unilateral absence may be found, in the absence of pathology in 3 to 5% of individuals, in the 40 to 60 age group, and in 7 to 10% of those over 80 years. To check L4 L5, ask the patient to dorsiflex both feet. Now attempt to force them into plantar flexion against resistance. Note the presence of any muscle wasting. Weakness of dorsiflexion of the great toe is a most sensitive test of the L5 nerve root alone. To check S1 S2, test the power of plantar flexion of the great and lesser toes. To assess L5 S1, encircle the feet with the hands, and test the power of the peroné against the patient's resistance. When a high disc lesion is suspected, test the power of the quadriceps, to assess L3, L4. Note that prolonged muscle weakness will be accompanied by muscle wasting. Look and compare the muscle girth of quadriceps and Carl's muscle of both limbs. Test sensations to pinprick in the dermatomes of the lower limb. Test perineal sensation in suspected central disc prolapse. Note also that stalking anesthesia may be found in diabetic neuropathy and peripheral vascular disease. If thoracic cord compression is suspected, it may be crudely assessed by testing the abdominal reflexes. Use a blunt object such as the handle of a tendon hammer to stroke the skin in each perumbilical skin quadrant. Failure of the umbilicus to twitch in the direction of the stimulated quadrant suggests cord compression on that side at the appropriate level. Beaver's sign. To check the Beaver's sign, ask the patient to place his hands behind his head, flex his knees, and sit up. Movement of the umbilicus to one side, up or down, suggests that the abdominal muscles on that side are weak, as compared to the opposite side. This may result from nerve root compression by an osteophyte, from a local tumor, poliomyelitis or spinal dysraphism. If ankylosing spondylitis is suspected, check the patient's chest expansion, at the level of the fourth inther space. The normal range in an adult of average build is at least 6 cm. Less than 2.5 cm is regarded as highly suggestive of ankylosing spondylitis. In addition, look for evidence of iritis, which is often associated with this condition. Suspected sacroiliac joint involvement. Ganslin's test. The patient positioned in supine, with the painful leg resting on the edge of the treatment table. The examiner flexes the non-symptomatic hip and knee. The patient should hold the asymptomatic leg with both arms, while the therapist stabilizes the pelvis, and applies passive pressure to the symptomatic leg, to hold it in a hyperextended position. If the patient's normal pain is reproduced, the test is considered positive for a sacroiliac joint lesion, hip pathology, pubic symphysis instability, or an L4 nerve root lesion. Meanwhile, the femoral nerve may also be stressed by this test. Sacral thrust test. With the patient in prone position, the examiner applies an anteriorly directed pressure over the sacrum. One hand is placed directly on the sacrum, and is being reinforced by the other hand. The purpose is to apply an anterior shear force to both sacroiliac joints, since the ilia are fixed by the examination bench. The test is positive if pain is reproduced in the sacroiliac region. Thigh thrust test. Patient in supine position, the hip is flexed to 90 degrees with knee bend, to stretch the posterior structures. One hand is placed beneath the sacrum to fixate its position, while the other hand is used to apply a downward force to the femur. The test is positive for pelvic girdle pain, if the axial pressure provokes pain, over the sacroiliac joint that is familiar to the patient. Abdominal examination. This is an essential part of the investigation of all cases of back pain. Rectal or vaginal examination may be required on the indication of the history, and any other elements in the case. The sacrococcygeal joint may be examined, by first grasping the coccyx, between the index in the rectum, and the thumb outside, and then gently moving the joint. Circulation. The peripheral pulses and circulation should also be checked in all cases. Back and leg pain caused by arterial insufficiency is usually aggravated by activity, and absence of femoral pulsation is of particular significance. Estimation of the sedimentation rate is a valuable screening test in the investigation of all spinal complaints. It is normal in prolapsed intervertebral disc, mechanical back pain, spinal stenosis, and Scheuermann's disease, but elevated in ankylosing spondylitis, many infections, and neoplasms.